Hello and good evening. I hope you had a wonderful weekend and are ready to start our live event tonight. And of course, just discuss another topic. With us tonight, we have our special guest, Dr. Raul Olivares. Hi, Dr. Raul. How are you feeling?
Hi, good evening. Nice to be here again with you.
We are happy to have you back as always, and you are, I'm sure, ready to present another topic for us. Before that, let me just remind you that we are here today, and also we are from the very 1st of April to support you through those uncertain times. We all know that slowly the clinics are reopening, so very soon most of you will be able to simply start off with your treatments, and we are definitely hoping that it will happen as soon as possible. But in the meantime, we definitely want to provide you with as much details, as much information as we can, and we want you to meet as many doctors as possible, so you can choose your clinics if you haven't, of course, already. And also, as always, let me thank to our ambassadors and partners that have been supporting those events, Stronger Together initiative. There are more and more of those ambassadors coming, and there are a few new faces on the screen as well. So huge thanks to them, as always. And well, tonight, as I mentioned, with us we have Dr. Raul Olivares. He's the medical director and owner of Barcelona IVF, which is of course located in Spain, and the topic is implantation failures, causes, and possible solutions. So we will start with a short introduction from Dr. Raul, and then we will go for those most common questions. And after that, as always, it will be time for your questions. So don't miss that chance and simply put your questions in the chat section. I just want to mention that as Dr. Raul is right now at the clinic, and the clinics will be just simply closing at 8:30 Spanish time. Therefore, we will tonight need to finish like in 1 hour and almost 30 minutes, so like 1 hour 20 minutes. So if we have more questions that Dr. Rowe won't be able to answer, as always, we will be able to forward them to the team and Dr. Raul, and I'm sure they will be able to get back to you. And well, that is it from me. Dr. Raul, hope you are ready to start.
Okay, thank you very much, Caroline. As I've said, it's really nice to be here again. It's a pleasure. Is another tough issue that I have to deal with because implantation failure is a complication condition that involves a lot of things. Though, well, one of the things that I really want to say about this is that the different tests available, the different things that we can do to deal with this tough condition I would say that the best word to describe them are, I would say it's promising. Promising because the quality of the evidence that we have from most of the tests, of the available tests, is not that strong. So sometimes is people read and gather a lot of information about a specific test that becomes on the top, the most famous, the new kid on the block, so it could be saying like that. And then until we get the information and we can scientifically confirm that what they offer is what we can get and it's going to be useful, it takes some time. Now the companies are doing the business, they promote the new test sometimes even too fast or before we can gather that scientific information that confirm the utility, the usefulness. And then we have to play a very delicate equilibrium between if we are doing the test, because we don't want our patients to pay the investigation of the company. So we need to wait until we can use them and be sure that they are going to somehow help the patients, there is, if I had to summarize the whole issue in a few words, I would say that the evidence nowadays is that probably up to 90% of the implantation failures that we have are due to embryo problems, not endometrium. So I know that there are dozens of tests available to check the endometrium, the hysteroscopies. If you want, we can discuss all of them, okay? But the embryo keeps being the key factor on having a successful outcome, okay? There is a very recent study. In fact, I think that it has not been published yet, that is based on more than it includes up to 9,000, close to 9,000 single embryo transfers that are genetically normal, and the results are quite clear. I mean, if you transfer up to 3 embryos in just 1, 2, 3 times, the chances of having a baby, live birth, are close to 90%. So that means that if after 3 single embryo transfers of genetically embryos, you have not been successful, then in these 10% of cases is when seemingly the endometrium, the implantation, other factors may play a role. Okay? So with this premise, with this idea, keeping in mind that the embryo keeps being the most critical factor to determine if the treatment is going to be successful or not, I'm ready to answer all your questions and discuss the different tests and the particular cases. I also learned from my previous seminars and from my previous webinars. So if you want me to tell you about your case, there are probably one thing that is critical, and if you provide it, it's going to be very useful, which is age. Age is probably the most critical factor to decide if we or to provide you with useful information. So whenever you make a question, just let me know your age, and because it is not the same when I have to answer to someone who is 34 than 44, as you can imagine. So absolutely ready. Let's start.
Excellent. Thank you so much for your introduction. As always, very interesting. And well, it is time for our most common questions. And the first question is, so how can I be sure that the implantation failure is due to a female problem and not an embryo problem?
Well, the thing is that they are very, very strongly correlated. Okay. One of the probably oldest questions that I remember to make to my professor was when we deal with the negative, which percentage of this negative can be due to the egg, to the sperm, or to the uterus? Okay, because in fact, when we talk about the embryo, we are talking about the egg and the sperm. Okay, though sometimes there could be other issues that are related, for example, to the laboratory, but I'm not going to get into this field because I'm going to assume that most of the laboratories that are nowadays working have really good conditions, you know. So when we have an embryo problem, it is because of the egg or it is because of the sperm, and in certain cases it could be due to the local conditions of the laboratory, medium cultures, and things like that. Well, it is much easier to study the male factor than the female factor. Okay, when we have an embryo problem, our standard way of working is to do some tests on the male side because it is easier to study, and then of course when we have that embryo problem, if the male side is normal, we can assume that as long as the laboratory is good, these problems are going to come from the women's side. If there is a male problem, then we have to be very careful because sometimes there could be mixed factors, and the fact that the male has a problem does not guarantee that the eggs are going to be healthy, but at least allows us to do changes or to carry out changes to see if we can isolate the oocyte, the problems from the oocyte. Okay, so whenever we have an embryo problem, let's start doing some tests on the male side if it's necessary, and once we are sure that the man is not playing any role on the embryo quality, then we will be able to see if the eggs are doing or have some kind of problem.
Oh, perfect. Thank you so much for answering the very first question. And let's have a look at the next one. So, which immunological tests are useful in cases of implantation failure?
Immunology is one of these things that was like the top issue in the 90s. Then we started with all the different genetic tests that started to be available in the 90s, PGS, and things like that. And then it was like kind of forgotten. And now it has come back, but in a completely different way. Okay. The whole histories back in the 90s were mostly based on even older histories that were developed, were issued in the mid of the 20th century, and they were based on the idea that there were kind of things that the body or that make the body reject the embryo. Okay, and this is why tests like natural killers, Th1, Th2, CD19s, and things like that, or even some tests that were issued to detect the levels of natural killers and the endometrium were released, and it was supposed that if you had abnormal natural killers too high, or the ratio between Th1 Th2 were abnormal, you could be in the position of rejecting the embryo. And this is why a lot of therapies like immunoglobulins, steroids, soja, and intralipids were also released in order to cause kind of immunosuppression in these patients that were supposed to attack the embryos. I have to say that these theories are no longer valid. Natural killers are there. Natural killers must be in the endometrium, and they play a significant and relevant role in regulating the implantation of the embryo, but they are not cytotoxic as they were supposed to be, because there are other natural killers present in the bloodstream that are clearly cytotoxic. They attack cells, they kill viruses, they kill cancer cells. But the natural killers in the endometrium are just regulating how deep the embryo implants. So they have to be there, they must be there, and it is important not to interfere with their levels. There is no single study that has been able to correlate the amount of natural killers in the endometrium with recurrent implantation failures. So forget about all these old studies carried out on the blood test. Forget about biopsies to detect natural killers in the endometrium. And the only tests that are now promising, because the evidence that we have about them is still controversial, are those that in certain cases correlate the KIR receptors, which are receptors on the surface of the natural killers that interact with the HLA-C antigens that the embryos express. And depending on which is the profile of the key receptors, and depending on which genes express the embryo, we may have in certain cases problems. Problems that are mostly related with recurrent miscarriages and placental problems than not implantation failure. This is why I still think that we have to be very careful about doing this test when we have no pregnancy, not when we have pregnancies that end up in a miscarriage. But in my opinion, these are the only tests that nowadays are kind of useful in certain cases to try to maximize implantation rates. Key receptors and HLA-C antigens on the embryos.
All right, thank you so much for answering yet another question. Next one is up. How must the transfer be done to maximize the chances of implantation?
Well, our ways of doing I mean, there are two classical ways of doing the embryo transfer. Of course, I'm assuming that because this is something that almost all the clinics are doing right now, that these transfers are done and they are ultrasound guided. So that means that there is someone doing a scan in order to make sure that the tip of the catheter is placed in the right point. Okay. Because that's the only way in which you can be sure that you are just doing the transfer at the right place. Once you are doing this, well, there are clinics that prefer to carry out something called a mock transfer before starting the treatment, just to describe if the transfer is going to be going upwards or retroverted uterus, or you need to use a soft or a rigid catheter, or if there is any issue that can make it difficult. This is how I used to work many years ago, but we changed the way we're working, and now what we do is that on the day of the embryo transfer, we just place an empty catheter, ultrasound guided, in the right place. The catheter is empty, and that allows us to take our time to be sure that we are in the right point. In the transfer, time is critical. The catheters are designed in a way that they hold the temperature for 30 seconds. And the embryos are very sensible to temperature changes. So we need to be sure that once the embryo leaves the incubator, it is inside of the uterus in less than 30 seconds. So why did we change the way? Because we had patients that on the day that we were doing the mock transfer, everything was perfect. And on the day of the real embryo transfer, once the embryologist brought the catheter with the embryo, it took more than 30 seconds to get in. So basically, we decided to work like we're doing now. We do kind of a mock transfer with an empty catheter before, and only once we are sure and we can invest 30 seconds, 2 minutes, or 10 minutes until we are in the right place. Only once we are in, the embryologist picks the embryo up and brings it, and we transfer it. And by doing that, we are 100% sure that 99.99% of the transfers are done in less than 30 seconds, and that the embryos are gently released into the uterus in the right place.
All right. Thank you so much once again for answering this question. Next one is here. So my endometrium does not get a good thickness. How can I make it thicker to improve the implantation rates?
Okay, well, the thing is that sometimes it's even difficult to know which or what a right thickness is, okay, because the cutoff points are sometimes even different, and this is also something that makes very difficult to compare different studies, because it's like everyone is choosing a certain thickness as the minimum or as the best one, or so the thing is that, for example, in our case, we work with the 6 millimeters as the minimum thickness in an egg donation or in a cryotransfer. But this is a scan that is done on day 9, 10. And once we reach that 6 millimeters thickness, we are sure that once we do the embryo transfer, that is usually done 1 week or 10 days later, the thickness is going to be okay. Other clinics prefer to work with 7 millimeters. Other clinics prefer to work with 8.5. There are clinics that are keen on or prefer to work with a pattern, triple line, not triple line. What do we do when we don't get that minimum 6 millimeters that we are looking for when we prepare someone for an embryo transfer? Where sometimes we just need to increase the dose of estrogens. We prefer to work with a fixed pattern of high doses from the very beginning. I know that there are clinics or protocols that start with 4 milligrams, then go up to 6 milligrams, and some of them go up to 8 milligrams of estradiol. We usually start from the very beginning with 8 milligrams. So it's 2 milligrams in the morning, 2 milligrams at midday, 4 milligrams at night. And we do the first scan 8-10 days later. And by doing that, I would say that probably 95% of the patients have the right thickness. When this does not happen, we can go up to 10 or even 12 milligrams, and we take 4 milligrams every 8 hours. If we manage to get the right thickness, that's fine. Patients keep doing the same doses. When this does not happen and we have to cancel the cycle because we don't get the right thickness, we may sometimes use drugs like Cialis, which is the tadalafil, 10 milligrams or between 5 and 10 milligrams a day, because these drugs are supposed to increase the vascularization, making the vessels wider, and then it should be easier for the estrogens to reach the endometrium and to improve the thickness. Is controversial. In some patients works, in some patients does not work. Sometimes we may change the way they are taking the estrogens, and we shift from oral to transdermal. And in this case, we may use patches or we may use a cream to give the estrogens, and changing the way, because when you take it through the skin, the estrogens go straight away into the bloodstream and go straight away into the uterus. When you take them orally, there has a first passage through the liver that may remove part of the estrogens. So sometimes it's a good idea to use patches or creams, and you may get, or even a combination of oral and patches, and this may be enough to increase. And in those cases in which they keep the thickness keeps being really low, despite using these drugs, despite combining patches, creams, or increasing the doses. Well, this is difficult cases. There are certain studies that have confirmed that the endometrium can still be receptive when they are 4 or 5 millimeters thick. So in this kind of a rebel endometriomes, one option can be carrying out the transfer or carrying out a test to confirm that the endometrium is receptive. And if it is, try to see. I have patients with endometriomes that were 4.5 or 5 that they've been successful and they've got pregnant. And there are other cases in which we have tried a protocol in which we have combined high doses of vitamin E plus pentoxifylline for 2 or 3 months. And then we have tried to prepare the endometrium. And I've got not many, but probably 2 or 3 patients, because we don't have so many patients with this problem. But in the 2 or 3 cases in which I've tried this combination of vitamin E and pentoxifylline, I've managed to get a better endometrium. Sometimes I've not got a completely normal endometrium, but if the patient had endometriums that were 3, 3.5, I've managed to go up to 5, 5.5, and I've got pregnancies. So this could be the only different thing, apart from increasing doses, combining patches, orals, or adding tadalafil or Viagra in some cases, but I'm not really fond of Viagra. I prefer the tadalafil, that in some cases can help to improve the thickness of the endometrium.
And excellent. Thank you so much once again for answering that question. And next one, is it worth to add on anticoagulant therapy, aspirin or heparin, in cases of implantation failure?
Well, this is probably one of these kind of treatments that can be included into that rule of first, do not harm. And sometimes we are just giving treatments to patients, and when I read the protocols, is kind of surprising. No, they start from the first treatment with anticoagulants, with steroids, with antibiotics, with probiotics, and it's like they just trying, as we say here in Spain, try to kill flies with cannons, And I think that as doctors, we have to decide what is worth and what is not, and we don't have to use all the drugs from the very beginning, as we don't recommend all the tests from the very beginning. We just try to decide which is going to be useful for each patient. So these kind of drugs, aspirin and heparin, are based on or are recommended because there are some evidence that coagulation problems like antiphospholipid syndrome or thrombophilia may reduce the implantation rates. The data are really controversial because these conditions are mostly related with recurrent miscarriages, not with implantation failures. But of course, every year we learn more. And in this case, especially with regards to aspirin, we cannot discard that in the future we are going to identify other coagulation problems that may explain implantation failures. So I'm not really fond of start any treatment adding aspirin or heparin, but in cases of recurrent implantation failures, especially those cases in which we are sure that the embryos are of good quality and all the tests are completely normal and we cannot identify any factor that is causing this implantation failure, using aspirin and using heparin may be helpful. Another thing is how they must be used, because I see a lot of patients that start the aspirin too late or the heparin once they are pregnant. These are drugs that, if they are useful, should be started clearly before the embryo transfer is done. And the aspirin, to get a full effect, should be started at least 4 weeks before the embryo transfer. If you start on the day of the embryo transfer or you start it once you're pregnant, the implantation has already taken place, and you are not going to get any benefit from these drugs. So aspirin 4 weeks before the embryo transfer, heparin at the beginning of the cycle in which you are going to have the embryo transfer. But yeah, at least they do not harm. They don't cause any relevant side effects, like for example steroids. So in some cases in which everything seems to be okay, can be used, and maybe they are helping.
Of course, understood. Thank you so much once again for answering that question. Now we will go to the last question from those most common ones, and right after that, we will go with your questions. And the question is, so could a natural cycle improve my chances if I don't get pregnant using hormone replacement therapy?
This is quite interesting because I really think that yes, that the answer is yes. I would say that when a patient has her cycle, everything goes in a more fluent way, in a more I would say that the body is preparing itself to get ready to get a pregnancy. The HRT is a quite standard therapy, and we all prepare all the patients in the same way, starting the progesterone in the same moment, using the same doses. And well, we assume that this is going to work in most of the cases, and this is basically what the majority of the studies confirm, that in terms of live birth, the HRT and the natural cycle offer very similar pregnancy statistics. So I would say that as a first approach, of course, in those patients that have the natural cycle, because if the patient is menopausal, there is no other option, and we have to work with the hormone replacement therapy. But in those cases in which, you have patients with natural cycle and you are trying with an hormone replacement therapy, and especially in those patients that have been naturally pregnant before, regardless of the outcome, even those patients that got pregnant and had a miscarriage, but they have been able to have an embryo implanted. In those cases, changing the hormones and going to a natural cycle, and then we say probably what we call the natural modified cycle. It means that we just monitor how the follicle grows, and once the follicle has reached like 17 millimeters or something like that, we trigger the ovulation with HCG in order to be sure that we transfer the embryos at the right moment. So this is kind of a natural modified natural cycle, it could be a good solution, a good answer. And in cases that we have had negatives in using hormones, we have managed to get positive using the natural cycle whenever it has been possible.
And excellent. Thank you so much for answering this question and all the previous ones. And of course, it is time for our patients' questions. As you can already see, there are plenty of questions already. So let's not waste any minute and go. Let's go to those questions. Okay, Dr. Raul, are you ready for them?
Yeah.
Excellent. So here's the first question. Hello there. We have had 3 fresh cycles with ICSI. Our 3rd cycle was the farthest we got and had transfer at day 5, but it wasn't quite a blastocyst at the time of transfer. Unfortunately, still did not implant. We have been diagnosed as male factor infertility, low ovarian reserve, and low AMH. I'm 40. I am thinking, let me go to the second part. Just give me a second. It's right. I am thinking for our 4th cycle, we will go frozen and do 3 times batch cycles and do frozen transfer instant. I am thinking if we have enough embryo then to do PGD testing too, as well as ERA test.
Okay. As I've said at the very beginning of the webinar, embryos are critical. Okay, I would say, as I've said at the beginning, probably close to 90% of the implantation failures are due to embryo issues. Embryos that can come from the egg, from the sperm, or even from the embryo itself. So before considering any study on, let's say, the woman side, and this includes endometrium, uterus, or blood work, okay, we need to be sure that the embryos that we are transferring are of good quality. And this is sometimes quite difficult because there are factors involved in the implantation that we barely know, okay? For example, there is a very recent study that has been testing the implantation rates of the embryos when they were genetically normal. And they have, because of the large data that this study has included, they have been able to notice that there are different implantation rates, even when we transfer genetically normal embryos, based on the age of the woman. And what does this happen? This happens because there are other structures that come from the egg that are relevant for the embryo evolution. For example, mitochondria. The mitochondria are structures that come from the egg and are the ones who create the energy that the embryo needs to go ahead with the cell divisions. So genetics is really very important, but it's not 100%. In your case, because focusing in your case, we are dealing a mixed factor because there is a male problem and we have someone who is in her 40s with a low ovarian reserve, so that means that it's really difficult to get eggs. My recommendation would be, first, study your husband. Carry out some studies on the male side, specifically genetic tests to detect if he's carrying a chromosomical issue or if there is any genetic problem in the sperm affecting, for example, in terms of which is the percentage of sperm that is carrying genetic abnormalities. We know that when there is a male factor, it is not so uncommon to find that even sometimes the spermiogram can be normal, okay, or despite being normal, there is a high percentage of sperm that carries genetic abnormalities. This is something that can be tested with a test called FISH or a meiotic study on the sperm, okay? So, and once we are sure that the sperm is okay, the only thing that we can do to check the quality of the eggs is, as you've said, a PGS. But if you test the sperm and you see that the sperm has a problem, and one thing, this also can be tested, for example, doing a DNA fragmentation. If you have a problem on the male side and you have few eggs of a not very good quality, it's going to be very, very hard to obtain healthy embryos. So probably you would have to consider to change something and see, for example, in the event of a an abnormal result of a fish or of a meiotic study or a DNA fragmentation, you would have to consider what your oocytes are able to do before with a normal sperm, and then probably consider a sperm donation. Let's say that you want to go ahead despite or regardless the results of the main site. Well, what you have done makes sense. What you have suggested makes sense. So you can just go through different cycles to do kind of an embryo banking to carry out a PGS and to make sure that the embryos are genetically normal. And then depending on the results of the PGS, you could decide if it's worth doing some research on the endometrium side. But first, wait until you get the results of the PGS. If you can test 6 embryos and only one is normal, it will be very clear that the problem is inside of the embryos, and I would not consider an ERA test in that scenario. If you check 6 embryos and 5 are normal, something very unlikely, but if that happens, it would probably mean that the embryos are not so relevant, and then it could make sense to do some research on the endometrium side before you transfer those embryos. But as I've said, focus on studying the embryos. First, the male, because it's easier, cheaper, and would let you decide if you want to keep working with that sperm or not before you start doing IVFs, and you will be also aware of what you can really expect from those IVF, taking into account that you may be dealing with problems on the sperm and on the eggs.
All right, excellent. Thank you so much for your question and that thorough information for the patients. Okay, well, I just need to show you that. Excellent. Thank you for much detailed reply.
You're welcome.
Thank you so much. All right, let's go to the next question. If PGD tests have been done on the embryo and the embryo has presented as a 100% normal point and there are no endometrial layer or womb issues, but implantation still fails, what could the cause of that be? I am 36.
Okay. And unfortunately, even if the embryo is genetically normal, we are still far from 100% success rate. Okay. According to a recent study that has not been published, as I've mentioned at the beginning of the webinar, the estimated live birth rate when you have transferred 3 genetically normal embryos is close to 90%. It could be in the first, in the second, or in the third attempt. The estimated live birth for the first attempt when you are transferring a genetically normal embryo and you are young is about 60%, which is slightly higher than tossing a coin. So it's not that really great. These are the limitations that we have as because we are human beings. So what happens when we are transferring an embryo and it does not implant, a genetically normal embryo? The first thing that I would suggest is that we need to consider more transfers until we get, and we should not be worried until we have transferred 2 or 3 genetically normal embryos, because even in those cases, we are not going to have 100%. So things that can happen when you are transferring good embryos and they don't implant. Probably nowadays, one of the things that is coming back is the adenomyosis, which is a condition that affects the structure of the uterus that can be diagnosed and sometimes is underestimated in the negatives. Adenomyosis is a condition similar to endometriosis, but it affects the muscles of the uterus. There are different things that can be seen on the scans that suggest there could be adenomyosis, and it has been confirmed that if you, I think that there's a study that describes up to seven things that can be related to adenomyosis, and this study confirms that the more of these things that you have, the lower the implantation rate is going to be. How can be adenomyosis improve? Well, we are now working with long down-regulating protocols using GnRH agonist, okay? So kind of creating a menopause menopause are for 2-3 months, because the adenomyosis is like the endometriosis, is hormone dependent. So if you just reduce this before transferring the embryos, you may improve the implantation rates. But adenomyosis should not be treated before the stimulation, because these long down regulations may also affect the amount of eggs that the ovaries can produce. So the idea is that if you think that the adenomyosis can be the problem, you still go through an IVF, okay? You obtain the eggs, you create the embryos, you freeze all the embryos, and then you can start working on the uterine side to reduce the adenomyosis. In some of the cases, well, is becoming very notorious. All these tests that are now checking the microbiome, so that the flora that is inside of the endometrium, and there are some tests that are trying to know if you have the right proportion of the lactobacilli, the different bacteria, and they are suggesting antibiotics and probiotics to restore the normal environment in which the embryos are transferred. This is very promising for me, and I'm now doing the tests and the research, and I've got cases in which only after I've been able to restore the normal conditions, the patients have got pregnant. So this is another thing that can be done, and check these usually called Alice Emma test, but the idea is to check the microbiome to detect if there is any kind of dysbiosis. And things that are useless. For example, I wouldn't recommend going through a hysteroscopy. There is a lot of evidence that if everything is okay in the scan, the hysteroscopy is not going to add, or is not going to improve the success rate of the next IVF. So probably I would, with the information that we really have nowadays, I would stick to check if there is any adenomyosis, check if there is any abnormality of the microbiome, and in some very specific cases, the ERA may make sense. But the ERA, which is the test that assesses the window of implantation, is only useful in those transfers that are done using hormones. It is absolutely unnecessary if you can have a natural cycle. And as I've said before, in some cases, doing some research and try to see if there is any coagulation problem, either antiphospholipid syndrome, either thrombophilia, to later use heparin or aspirin, can also be a good option, because it's quite easy, quite simple. The treatments are not really expensive, free of side effects, so it could make sense.
All right, perfect. Thank you so much. And actually, you have already mentioned this, but the question was from the patient in regards to how accurate is an ERA test to increase the chances of implantation on a second round.
I mean, if you mean a second round of fresh IVF, the ERA is completely useless. Okay, the ERA is designed to work in a very controlled environment. So ERA only makes sense if your endometrium is prepared in the same way, using the same hormones, starting them at the right moment. In an IVF, the number of follicles, the level of hormones, everything is going to change from cycle to cycle, as it happens in the natural cycle. So forget about the HERA or any other test designed to identify the implantation, the window of implantations, if you are not working with hormones in either an egg donation cycle or in cryotransfers, in which you are exposed to a cellula. Because the ERA, once you have the ERA, you have to replicate the same environment and the same treatment once, twice, or 3 times. And every IVF, every stimulation is completely different. You can even work with different drugs. So it is absolutely useless in these cases. Only in cases in which you are under a fixed protocol of hormones that can be replicated, that can be do exactly in the same way in the future.
All right. Thank you so much once again. And well, there's already. Uh, Thank you so much. This is so helpful from the patient's
You're
opinion.
welcome.
Excellent. Thank you so much as well. And let's go to the next question that we have. So, will coenzyme Q10 and DHEA improve the quality of fertility? How long should we take, and how much to take?
Well, this is another. And I know that there are some groups, especially in the United States, that are really fond of DHA, DHEA, the European understand, these kind of things. With regards to the coenzyme Q10, I have to say that so far there is no evidence that it could improve the quality of the eggs. Okay, in fact, all the antioxidants that have been used and all the studies have not been able to prove any improvement with regards of the live birth rate when they are used in women. Men is another history, and some of them may be helpful if you are trying to improve the quality of the spermiogram. But in terms of egg quality, so far no antioxidant have proved to be useful. Androgens is another word and is again promising. I think that the main problem that we have with androgens is that we cannot identify yet the group of patients in which these drugs can be useful. We lack of the tools. Androgens have proved to increase the number of antral follicles. Okay, so if you have more antral follicles, if you stimulate the initial number of follicles that can potentially grow is going to be higher. Androgens have proved to increase the number and sensitivity of the FSH receptors in the antral follicles. So that means that if you have more receptors, you may need lower doses, or the doses that you are using may help to recruit more antral follicles, and then you may get more eggs. Okay? Androgens have been suggested to even increase or improve the genetics of the eggs. Has been based in some studies that have confirmed that younger girls have higher intraovarian androgen levels than older girls. Okay, and this is why it has been suggested that if we can somehow reproduce these conditions of the younger ovaries with higher levels of androgens, we may get more eggs, and in some cases it has been suggested that even better eggs. Okay, which is the problem? The problem is that we don't know for how long, at which doses, and what substances can be used to create or to reach or to obtain this improvement. DHAs has been suggested to use that you need to take it for 3 or 4 months. Okay. Well, are the patients are they basically, or are they? I can't find a word. It would be probably would they? Are they going to be? Oh, I'm sorry. I just got. The thing is that there is a very delicate equilibrium, because if we are going to make a patient who is 41 years old wait or invest 3 or 4 months taking this drug, okay, the benefit that we are going to get from this drug can be compensated by the fact that she's going to be 4 months old. Okay, yeah, so the word I eventually managed to get it. Are they willing to wait 3, 4 months, knowing that this can reduce their chances, especially in those cases of patients who are over 40? This is very delicate. So probably if you want to take DHA and you are 35, 34, and you can wait these 3, 4 months, well, it could be, but the results are not that promising in old women. So you have to be very careful about recommending or delaying a treatment 3, 4, 5 months for something that is not completely demonstrated, and knowing that your prognosis can be worse if you just delay the treatment 3 or 4 months. This is why. Uh, the only treatment that I sometimes have used is to add testosterone at the beginning of the cycle for a very short period of time, 5 to 7 days. So the idea is that the patient has a period, we add a treatment with higher doses of testosterone just to create this environment, at least to increase the number of receptors and to try to have more, not focus on improving the quality of the eggs. It's mostly focused on obtaining more oocytes, and then for 5-7 days we give testosterone, and then immediately afterwards we start the stimulation. And I've got some cases in which I've really been able to increase the number of eggs, and if we have more eggs, more chances of having a good embryo. So it's as I've said, the problem is mostly that we cannot identify which patients is going to be useful, that we don't know exactly the time that you need to be taking, and in some cases these 3, 4, 5 months can have a really negative impact on the ovarian reserve of the patients. And probably if you want to try them, my recommendation would be to use testosterone at the beginning of the cycle to make sure that you kind of have these conditions of a younger ovaries.
Excellent. Thank you so much once again for a thorough explanation to this question as well. And now next question is in regards to the surrogate. I hope you will be able to perhaps have a look at it. What is the most important things that a surrogate should do to make sure that the embryos implant and grow into healthy babies?
Well, I mean, of course, I would say that the surrogate should do what any pregnant woman should do. I mean, try to be as healthy as possible. But in terms of implantation, well, as long as the surrogate has a healthy uterus, there is nothing special they should do. And we are not really very strict with regards to the things that the patients can do after the embryo transfer. I mean, once we do the embryo transfer, we keep them here for a couple of minutes. We recommend them go back to their hotel or their homes and stay there for a couple of hours in order to try to relax the uterus, because sometimes when you manipulate the uterus, you can create kind of contractions and may interfere with the implantation. So we recommend a couple of hours of resting, and that's it. From that moment onwards, what we tell our patients is to consider themselves pregnant and do what a pregnant woman is supposed to do. And when someone is trying to conceive naturally, is living completely normal life until she has a positive. So if we recommend, take it easy, avoid strong physical efforts, and things like that, is must because of the psychological aspects of the treatment, and that in the event of a negative, the patient does not blame herself thinking that she could have done something different. But I really think that as it happens in the natural cycles, when the patients go to the gym, drink some wine, and have sex until they know, they are aware that they are pregnant, that this would not change that much the outcomes. Okay, so I would say just try to keep it as simple as possible. Try to lead a healthy, normal life, eat healthy, avoid toxics. Well, try to avoid strong physical efforts unless they are strictly necessary. And you can go to the gym, but adjust the intensity of the exercises to the condition of pregnant. You can do yoga, you can do whatever, but as if you were pregnant.
All right, excellent. Thank you so much for answering this question as well. Next question is a short one. What has higher success rates, fresh transfer versus frozen transfer?
I know that there has been a really important trend of people that has thought that it was worth to freeze all the embryos and to carry on a kind of a freeze all treatment, because they were suggesting that the conditions of the endometrium could be different after a hand stimulation than in a normal cycle. Well, I'm now in the position, because there was a really study published last year, 2019, that has confirmed that the endometrium has exactly the same conditions after an stimulation or in the natural cycle. So there is no reason to carry out a freeze all systematic treatment. I mean, the pregnancy rates, and we don't recommend that. We only recommend freezing the embryos when there is any kind of a medical indication to do that, either because the patient has a breakthrough bleeding or because the thickness of the endometrium is not okay, or in cases in which there is a risk of hyperstimulation syndrome or any other issue that recommends canceling the cycle. But if not, there is no advantage. And in fact, when we do this kind of freeze all treatments, okay, because of any of the reasons that I've explained, we have confirmed that the pregnancy rate that we have in the first frozen embryo transfer is exactly the same than the pregnancy rate that we have in the fresh transfers. So it is not better, it is not worse, it is exactly the same. So based on that, there is no reason to delay the treatment if there is not any medical condition that recommends doing it.
Excellent. Thank you so much for clarification. That is very common question. So indeed, thank you once again. Now we have two parts of the questions, okay? A question. So here's the first one. What is your opinion about biopsy testing the endometrium? For example, doing a mock cycle and testing the dating and quality of the endometrium. I've heard doctors, they say that the data is valuable, and others that say that there is no relationship between 1 month and another, so there is no point in doing a mock cycle. And let me just go to the second part. To clarify, I am talking about a donor egg frozen cycle for a 51-year-old woman who has a child with her own eggs. She has had 3 DE unsuccessful transfers of day 5.
Okay, this is basically what I was saying at the very beginning. I mean, if we are talking about doing embryo endometrium biopsies in natural cycles, that's a completely waste of time and money, because the conditions of these endometriums are going to change from cycle to cycle, as it happens in IVF, as it happens in the natural cycle. So there is no point, and this is a whole history that has been abandoned for. The thing is, when we are working in a controlled environment, using a standard protocol like an hormone replacement therapy, and we have no option because the patient is menopausal and she does not have a natural cycle. That would be my first option if the hormones aren't working. Okay, in these conditions, well, a mock cycle, I would say that rather than talking about mock cycle or a cycle, I would say, what are you testing? Because there are things that can be tested, and they are going to be exactly the same in one cycle and another cycle, and things that can be completely different. But if you reproduce exactly the same conditions, in some cases, in most of the tests that we currently have available, the conditions are not going to change. So that means that if you go and test implantation, the window of implantation, and you reproduce exactly the same cycle the next month, starting with the same doses of estrogens, starting the progesterone on the day that you've been told to do it, and the same doses, the conditions are not going to change. And there are some studies that have confirmed that once you have an ERA test, and if you do the same conditions 1, 2, 6 months afterwards, the window of implantation does not change. If you test the microbiome, as I've said before, and you confirm that the bacteria are okay, they are going to be okay in the next cycles. If they are not, of course, you would have to decide if you want to go through a treatment of antibiotics and probiotics to restore the normality and carry out new biopsies to confirm that the conditions have changed and are again normal. So rather than talking about mock cycle, or is what do you want to test? And of course, always under these conditions, fixed treatments, reproducible treatments that can be not in the natural cycle, not after stimulation.
And perfect. Once again, huge thank you for that as well. Okay, next question is up here. How many days after implementing should we test for pregnancy result?
Okay. This is basically relevant for patients who undergo IVF or intrauterine inseminations because sometimes they tend to do the results too fast and they get false positives. And the main reason is that when we trigger the ovulation, we are using HCG, which is the drug that is detected by the pregnancy test. Okay? So sometimes patients come and they explain that they've had biochemical pregnancies, and when you make questions about the treatments and things like that, basically you detect that they were doing the test very, very early. Okay? HCG may need up to 7 to 9 days to get clear from the bloodstream. So if you do a pregnancy test on the day of the embryo transfer, I would say that probably in 70% of the patients is going to be positive. Okay, so of course, if you are doing a cryotransfer, if you are doing an egg donation where no HEG is used because there is no ovulation triggering, then the results can be, I mean, if you do the test too far, too fast, or too soon, you are going to get a negative probably. I would say what we're usually doing is we do the embryo, the pregnancy test 12 days after the transfer. That's because we usually recommend to have the first test done in urine. And in urine, if you do the test too close to the embryo transfer, it's easier to have false negatives. So, but if you want to do the test in blood, probably if you do the test 10 days after the embryo transfer, if you are pregnant, you're going to get a positive.
Okay, excellent. Thank you so much once again for this. And well, next question is here as well. And let me show you that. You mentioned NK cells earlier and how they should be presented to some extent. What about the Th1, Th2 cytokine ratio? You can see the details. So,
Yeah,
so
yeah.
are
The
abnormal,
DNA, the
right?
necrotic factor, the interleukins, and and ratios are abnormally high with this compromised implantation. No,
Thank
not
you.
at all.
Excellent.
Yeah, yeah. Now, these are basically, I mean, the fact is that that the ratio of the Th1, Th2 is we don't know exactly which is the normal ratio. So it's really difficult to know which is can we tell that this abnormal if we don't know which is the ratio. In fact, the ratio of the THA to Th2 changes a lot between the different patients and in different conditions. As I've said, all these kind of things, cytokines, interleukins, necrotic tumoral factors, are kind of things that were supposed to somehow detect implantation failures, but so far most of them are abandoned. My feeling is that in some patients they could be useful, but we are far from knowing who is going to get any benefit from this, and how are we going to restore the normality when these kind of things are abnormal. So we don't use them. We don't recommend this kind of test because the lack of evidence in terms of correlating these results with ongoing pregnancy rates, because the lack of evidence with regards to the treatments and have been recommended to deal with these conditions. They have not been as useful, and there are no studies that have confirmed that you can get any benefit from them. So until we don't have more evidence about what is really going on during the implantation, I don't think that steroids, intralipids, immunoglobulins should be recommended based on this test, because there is no evidence that you are going to improve the outcome.
All right, excellent. Thank you once again for answering this question. And actually, there is another one from the very same patient in regards to ERA. Okay, I
Mm-hmm.
have done the ERA test twice. Once I was preceptive, the next time post-receptive. So their recommended number of hours was in the middle of these two. Based on what you said earlier, is it worth all me doing a fresh transfer, or should I always only do frozen? If I do fresh, should I try to arrange the transfer at day 5? As close to the number of recommended ERA hours are possible, and my ERA recommendation was about 133 hours.
Okay. Once more, I have to say the same thing that I've said before. Do not extrapolate the results of the ERA to a natural cycle, to a stimulated cycle, because they are completely different. ERA is only useful in cases in which you can reproduce the treatment or the protocol that you have used to do the ERA, to carry out the ERA. Your case, well, when we talk about the window of implantation, there are cases in which is pre-receptive, means that this displays and it takes place later than usual, post-receptive, which means that the endometrium is ready before what it should be, okay? And then you need fewer days of progesterone. And in some cases, the companies that promote the ERA, they say that there could be a narrowing of the implantation of window. And this is why sometimes you get a one pre-receptive. They basically tell you to adjust the when do you have to start the progesterone, and you get a post-receptive. That means that the period of time, usually the window of implantation is thought to be like 3 days, but in cases like yours, it could be just 1 day, 1.5, and then you have to stick to the results of the ERA, because if you do the ERA, the logical thing is to then later follow the instructions that you get. So my recommendation in your case, it would be, if you want to use a natural cycle because you can use a natural cycle, forget about the ERA. The ERA has nothing to do and is not going to help you anyway, anyhow, when you're trying to work with that. If you need to work with hormones, either because you are doing an egg donation and you need to be synchronized with the donor, or because you don't have natural cycles, then follow the instructions of the ERA and try to have your embryo transfer between the margins, the hours that you've got in the two different cycles.
All right, perfect. Thank you so much for again clarifying. This is definitely indeed important. So huge thanks. Again, one more question from the patient. So for testosterone treatment, when to start? The day period starts and it can be taken alongside stimulation medications, or do you mean it should be started 5-7 days before period comes and before stimulation is started?
Yeah. Well, the testosterone should be started, and the treatment should be done before you start the stimulation. Okay, so you have to somehow keep the patient down regulated for those 5 to 7 days until you can start the stimulation. The standard protocols are two. One is we use low doses of GnRH agonists that are started on the 1 week before the patient has her period. And then once the patient has her period, we reduce the dose of these down regulation drugs, and we give the testosterone for 5 days, and then we start the stimulation. Okay. Or sometimes, if we don't want to use these drugs because the ovarian reserve is really low, we may get the same effect adding estrogens at the end of the previous cycle. So that means that the patient starts with the estrogens, the Proginova or any other estrogen, 1 week before she has the period. Once she has the period, she continues with the estrogens, and we add the testosterone, and 5 days later we stop everything and we start straight away the stimulation. So the idea is to give the testosterone for usually 5 days. I've said 5 to 7, but usually 5 days before we start the stimulation, either in a long down regulation protocol using low doses, because we cannot forget that these protocols are used on patients with a low ovarian reserve. Okay, so we don't we can't work with really strong down regulations because this may affect the response that we're going to get later. So low doses down regulation or estrogens, just to make sure that the ovaries do not start working during those 5 days in which we are going to try to prepare them giving testosterone.
All right, perfect. Again, many, many thanks for that. And there are like approximately 10 minutes left. Okay, so let's go ahead to some of the questions. If we will not be able to answer all of them, of course, I will forward all the questions to the Dr. Raul and his team, of course. And the question here is, I'm 46 and I did my first embryo transfer in October 2019, which was negative with the egg donation. I did just 2 endometrium checking on my 8th day and 12th day of cycle menstruations. It was 8 to 12. The second frozen embryo transfer, it was in January 2020, and my endometrium liner, it was as well the same. My result, it was negative. I want to specify that in both cases, my transfer was done in the 19th day of my menstruation cycle. In February, I did an hysteroscopy and they found some inflammation in preparing for the next transfer, and I need to know what I can do.
Okay, so I'm going to assume that you had blastocyst transfer, not day 3, and I'm going to assume that you've had only one blastocyst each time. And I'm also going to assume that there is nothing wrong on the male side, that there is no male factor, or that you are using an sperm donor, but that there are no other problems than that. As I've said, after 2 transfers of 2 blastocysts, and assuming that they were genetically normal, we should not forget that even an egg donor has a 20%, 25% of the embryos created after an egg donation are going to be genetically abnormal. Okay, so having a good embryo, when I mean a good embryo, I mean a good morphology and good evolution and everything, does not guarantee that the embryo is genetically normal. Okay, when I've previously mentioned that 90% live birth rate, I was talking about embryos that were certified to be genetically normal, something that in some cases cannot happen in an egg donation. You've had, it is not the same if you've had 2 blastocysts transfer in each transfer or you have only had 1 in each. Obviously, if we assume no male factor and blastocyst transfers, well, as I've said, the hysteroscopy does not usually help to improve because it's very subjective. This kind of inflammation, and we now have tools like this test to assess the microbiome and the chronic endometritis that are much more specific, or you can do an embryo culture and see that this inflammation is related to any bacteria, and then go with the right antibiotic treatment, and also consider probiotics to restore the normal flora of the endometrium. If you cannot have this specific test done, what I will suggest is an empiric treatment with a course of antibiotics for 7 days using amoxicillin or clavulanic acid, and then using vaginal probiotics to restore at least 20. But I would consider a 3rd transfer because, as I've said, we are, even with these 2 good embryo transfers, we do not have 100% success rate. So sometimes it's just a matter of keep transferring. So based on, of course, if there is any male factor or any other thing, these are kind of things that should be taken into account. But in your case, assuming that everything else is normal, probably if you can have more specific tests to identify this inflammation and to try to identify if there is any endometritis, which bacteria, if there is any dysbiosis of the endometrium that can be treated. And if you cannot have the test, then go for a course of antibiotics, continue with a course of vaginal probiotics to restore the normal environment. And if it's possible and you've been using hormones and you still have your natural cycle, change and do not use hormones and try with the natural cycle, and probably and you may get a positive if you fix all these kind of things.
And perfect. Once again, thank you so much for all your advice on that as well. And I believe that this might be our last question, right, Dr. Raul? And of course, I will forward all the rest of the questions to you and
Mhm.
your team. Okay, so here's the question. Do you recommend PGD test before embryo transfer? My embryos were frozen when I got diagnosed with colon cancer. Should I be worried about using them? The quality.
No, I mean the colon cancer has no. I mean the only thing that we can do nowadays, in some cases of cancer, for example, in cases of breast cancer, there are some mutations and genes that are related to a higher risk of having cancer in the babies, and this can be identified in the embryos. That these genes are called BRCA in the breast cancers. Okay, I don't know if your colon cancer has some kind of genetic background, and if you have some kind of genetic background that increases the risk, and this can be inherited by your babies. Well, it could, I don't know but it could be possible to test if the embryos have the same problem than you, and then discard those embryos that are at a really high risk of having a cancer. But in terms of implantation, in terms of getting pregnant, the colon cancer, if your embryos were frozen before you had the chemotherapy and all your treatments, are going to be as good as they were when they were frozen. Okay? And in terms of PGD, PGS, that depends on whether there are risk factors or not. Despite of all the things that I've been saying, that even in egg donation, 20% of the embryos may have genetic issues. I'm not really fond of doing genetic testing in all the embryos. I only think nowadays it is still an invasive technique. We need to make a hole, we need to disrupt the trophic to them, to take some cells out. The, all the studies, there is not so much evidence because it's a quite new technique that is now the PGS on blastocysts is available since 10 years ago. So that's the all the evidence that we have, no? And seemingly does not have any midterm or long-term effect, but it is an invasive procedure. So we don't want to stress the embryos more than what it is strictly necessary. And we only recommend PGS when we think that there is a high risk of having genetic problems, either because the woman is too old, either because there are recurrent miscarriages, either because there is a kind of a male genetic factor, karyotype abnormalities, or kind of mutations that can be inherited by the baby. But if your embryos were frozen when you were 33, you should not consider PGS in these cases.
All right, excellent. Thank you so much for all those questions. As I mentioned, we will be finishing for tonight. However, I definitely want to assure you that I will forward those questions, that the ones that haven't been answered. So don't worry, Dr. Raul and his team will be able to get back to you. Sorry. And of course, well, Dr. Raul, as always, you've been excellent. Thank you so much for joining us once again. And I do hope we will have more and more of those coming pretty much soon as well. And of course, I just want you to see that there are some thank yous already, as you know. Thank you so much. Thank you for the information you've provided. And actually, there is one more. Thank you so much for excellent facilitation. I am so impressed with this doctor. I have been doing fertility related treatments for more than 10 years. So I have met many doctors there anyway.
Absolutely. It will be a pleasure.
Exactly. I already have sent
If
you
I
the
just
link.
can add, if I just can add just a few words, because that's something that is really important, and I think that should be stressed out. It, we cannot forget that most of the available tests and all the companies that promote these tests are the same companies who design the studies that used to try to convince us that they are useful. Okay, so we still lack of the necessary objective independent studies that confirm that these tests are really useful, because obviously the companies are going to tell us or are going to show us only the tests that are useful, or the studies that somehow confirm that their tests are useful. I can tell you that there are now really a lot of ongoing studies trying to see if, for example, the microbiome and all these tests are really useful, combining groups of patients who are treated with antibiotics, with placebo, that there are also studies that are trying to see if this, for example, we have not talked, which is something that has surprised me a bit, about the endometrium scratching. But there's a really a big study with close to 1,400 patients that confirm that it is not really useful, at least in general. There could be other groups. There is now a really big study, an ongoing study, that is trying to identify in which subgroup of patients endometrial scratching may play a role. So this is still alive, and the main problem that we have is that most of the tests that we currently have are promoted by the same company creating studies, and therefore we have to be very bit careful about this data, because we need independent data, and this is what we try to do. And this is why, for example, we are not so fond about ERA. Once ERA was released, we did a big, we did kind of 120 cases, and the results that we had were not those that the company wanted to or showed us. No, so try not to be fashion victims, because sometimes it's really difficult with Google and all the available information.
And fantastic. Thank you so much for that clarification as well. I mean, it means a lot to all of us actually, because we all should be aware. Yes. And of course, as you can see, I feel so hopeful after hearing on the scene. Brilliant webinar as always, really. And
Thank you. Thank you.
really honest talk. Thanks so much. So,
Mm.
once again, huge thank you. And everyone, I just want you to remind that this has been recorded. You will have a chance to rewatch it on myavms's.com. And of course, it will be uploaded very, very soon. And I just can only encourage you to join our next webinar that will start at 8 p.m. UK time. There is another doctor that you might be familiar with, Dr. Diana Bidniak, and I hope I can see you there as well. Thank you, Dr. Raul. It has been a pleasure. It is definitely always a
My
pleasure.
pleasure. My pleasure.
Enjoy your evening and,
Thank you.
well, till the next time, right?
Perfect. Yes. Hopefully, yes.
Excellent. Thank you so much. Take care,
Bye
everyone.
bye.
Bye.
Take care.